Good afternoon, everyone, and welcome to our live Q&A session. I'm Xavier Koitkin. I'm a surgeon at the University of Chicago. We have some of our speakers here this afternoon with us. We have Courtney Lawn-Heath from UCSF. We have Eloisa Soares from the University of Utah, Jadira Del Rivero, from the National Institutes of Health, and then we have David Metz, just retired from UPenn, but still a very active member, obviously, in the neuroendocrine tumor community. We're very happy that you're joining us. We really hope that you enjoyed this 4 or 5 hour long sessions and these talks that we provided to you. And thanks again for the Neuroendocrine Tumor Research Foundation to put this meeting together for us and with us. So let's talk and dive right into it, if you don't mind. So first question that we had is going to be a question for Dr. Metz. And the question was, how should our diets change after being diagnosed with a neuroendocrine tumor? Are there certain foods that we should stay away from? Or are there certain foods that we should eat more of?
That's a tough question, actually, because obviously there's always a balance in life. People need to enjoy what they're eating, but if you get side effects and complications relating to your diet, obviously it can make life quite miserable. I would say that generally speaking, most of us in the United States and many people around the world are consuming too much in terms of fat and sugars. We're probably overdosing it on meats. And the real idea is to have a good balanced diet, regardless of whether you have a tumor or not. Obviously, in addition to that, some of the syndromes are going to have impacts that might affect health that you can affect with diet. And clearly the sugars and diabetes is the issue to worry about there. And as I alluded to in my talk earlier, if you have loss of pancreatic enzymes, either because you've lost your pancreas or because you're on a somatostatin analog, which dries up the pancreas, you may not tolerate fats as well, and you can get what's called steatorrhea, which is essentially diarrhea from malabsorption of fats. We don't want people to limit their diets too much, of course, because if you over-limit your diet, you're going to get deficiencies. And generally speaking, I think it's important for any neuroendocrine tumor patient to see a dietitian at least once to learn about healthy diets and to try and follow a regular healthy diet. And in fact, this last session had my mouth watering. I want to try that salad myself. So let's quickly run through a couple. If you've lost your gallbladder, important there is that you can get bile salt diarrhea. And as I alluded to, that can be bound up with certain medications, and fat malabsorption may be a consequence. If you've lost your terminal ileum because of resection of a terminal carcinoid, vitamin A, D, E, and K is absorbed in that location, and the fats are absorbed in those locations. So a low-fat diet, but be sure not to limit your dietary intake of appropriate vitamins. But generally speaking, I think the idea is to eat a healthy diet as much as possible and to watch your weight. I'm more concerned in patients with neuroendocrine tumors who are losing weight than patients that are potentially gaining a little bit of weight. Weight loss is a very worrisome thing in neuroendocrinology, and to me is something you need to be very aware of. And that to me signifies significant liver disease in many cases. So healthy diets, look for deficiencies, limit your fats, beware of diabetes, and I think fat malabsorption is something to consider.
Great. That's a very comprehensive answer. Thank you so much. Josh, as a patient yourself, have you seen a dietitian throughout your course?
So many times, depending on the treatment that I'm on and what's going on, I will go and review that as well and look to eat both healthy and to review it as different medications may change my GI tract and what's going on in my bowel habits. So I'm not only early on in my diagnosis, but as different treatments changed, I have gone back and consulted with my dietitian. Last year had SBRT, which impacted the diet I had, and now I'm on a different drug, which has again impacted my diet and had a visit. I will say one thing to this question is I don't think there's a pat answer, right? There's not one we are all different, as Dr. Metz pointed out, and we need that individualization of the diet planning. And I think the other thing, working with a lot of patient groups, we have patients that are incredibly worried about, sugar in their diet and should they cut off everything? And I think that's probably one of the number one questions. And again, as Dr. Metz pointed out, moderation is the key and learning to eat a healthy diet, but the elimination of everything, probably other than fried food for some of us here, but is what's going to make us healthy and move forward.
Great. Thank you so much. All right, let's jump to question number 2. That's going to be a question for Dr. Jadira Del Rivero. How frequently should someone have CT scans after having surgery to remove a neuroendocrine tumor? And should we only have a certain number of CT scans per year?
Well, yes, thank you so much, Dr. Kutin, for the invitation. And thank you so much for a very good question. I feel like sometimes, depending on where you are, maybe the timing of the scans may be different. And I will also like to know the thoughts of Dr. Suarez as well. Usually after surgery, I like to have a CT scan, CT or MRI, anatomical imaging studies, that's what we call that, versus the functional imaging studies. Functional imaging studies, it explains to me the functionality of the tumor, whether it's an DOTA scan or a FDG PET scan, which is a glucose scans. CT and MRI tells me more. We call it anatomical scans because it takes me more, explain to me more delineation of any of the tumors. That said, usually after surgery, I like to have scans anywhere from 6 months for the oncological perspective. Sometimes I feel like the surgeons like to have scans 3 months after surgery. For me to understand what's going on is more about 6 months after that for the first year. And then after that, I can do scans, depending on what I'm seeing, I would say every year after that. And usually I like to do that if no evidence of disease, or depending on where the status of the tumor is, I like to do scans once a year for about 10 years or so after surgery, considering there is no evidence of tumors. That said, when there is an advanced setting, in the metastatic setting, of course, the frequency may be a little bit different on how we do that. I don't know, Dr. Suarez, what are your thoughts about that?
Thank you so much, Dr. Rivera. And so that's an excellent question. And I just probably would add that also take into account where's your primary tumor and the stage that you are, they might be very different. And I'm just going to be cite this because for folks that have this disease, you may say, why I'm not getting scans. For instance, if you had a very small appendiceal neuroendocrine tumor that was resected and was less than 1 centimeter in size, there's a very good chance that your team told you might not need any scans moving forward. And that is most likely the very much appropriate question, answer to that because of the nature of the disease. But on the other hand, if you have a resection of your pancreatic neuroendocrine tumor that is a well-differentiated grade 3 tumor with several lymph nodes involved or even metastasis in the liver that were resected at a time, there might be a very good chance that your team might decide to do the scans initially, as was alluded, every 3 months or every 4 months for several years before they move to once a year and so forth. I 100% agree with Dr. Del Rivero that for most of the patients, we tend to follow these patients for a minimum of 10 years if follow-up is required. Another time that potentially follow-up with imaging is not required long-term, and Dr. Metz can comment on that, is some of the rectal cancers. The polyps, if they're very small, and there's no evidence that there was any disease left on the colonoscopy, they might not require long-term follow-up. And these are some of the caveats of the discussions that Dr. Rivero, or additions of the discussion that Dr. Rivero already cited.
Thank you very much. Yeah, I think as a surgeon that does these surgeries, I think it's very important, like both of you mentioned, to differentiate. Are you looking at curative intent surgery, so somebody that had limited disease, that you have resected all of the disease of, that you think has a good likelihood of being cured? Those patients, I generally do 6 months for the first year and then once a year afterwards. Very important to extend it up to 10 years because I've heard so many stories of surgeons that have told their patients, you're cured, and then they scan them, 2 years, maybe for 1 or 2 years, and then they forget about it. And then 6 years later, something does show back up in the liver. Remember, well-differentiated neuroendocrine tumors are slow growing, and most of the time it can take quite a bit of time until they come back. In the metastatic setting, as somebody that does liver debulking, I actually like to do a 3 months postoperative scan because the 6 months helps me then compared to the 3 months. So the 3 months after we target the liver with, wedge resections and, microwave ablation, it looks like a bomb exploded in the liver. You got cavities all over the place. You don't really know what's going on. You don't know what's vital, what's not, what's alive, what's not, what's behind, what's not. And so I like to do 3 months, and then I will do a 6 months afterwards, just to see, because then you can start to see, if things are clearing and shrinking, if things are growing. Obviously, a post-treatment liver lesion should not grow. So then perhaps you have left some tumor behind. So that's something I think that plays a role as well. But I think, as both Dr. Del Rivero and Dr. Soraya said, it's important to follow long-term, and everybody has a little bit of a different way how they follow these. It's just important to keep an eye on things.
Can I just jump in?
Yes.
Wanted to talk about that because that's something that I get asked a lot by my PROT patients, and I'm sure is a common concern. These are right. When we're measuring life expectancy in years and possibly decades, we do have to worry a little bit more about cumulative radiation exposure across a person's whole lifespan. That being said, a CT scan every 3 months is not going to be that worrisome. And we're talking about even less of a frequency in many patients. Generally, you'd only have every 3 months or something like that if you're immediately post-op, as Dr. Koitgen was saying, or if the tumors are growing or there's some questionable finding that you want to follow up and make sure that it's stable. Otherwise, it'll be even lower frequency. And frankly, we think really hard as physicians treating NET patients, balancing kind of the known, we know that there's some cumulative risk. There's no actual threshold where it's like, okay, well, you got 1,000 CT scans, now you're going to get cancer. That's not, there's no threshold like that, but we know that probably more scans is, may increase your risk. But again, it's really a drop in the bucket over time, and physicians really take into account whether or not a scan is needed before ordering it. So it's something, to some extent, I think it's great that everybody's thinking about this and keeping it in mind. And it is something that docs need to keep in mind. But for the most part, your doc should be keeping it in mind.
Thank you very much. And also, there are CT scans, and then there are MRIs as well, right? So those don't have any radiation. So it depends which one you prefer. I personally prefer the latter when it comes to the liver. But so, and you can also switch things around, so there's a lot of ways to deal with this. But thank you very much, Courtney. That's a very good point. Next question is for Dr. Metz again. So can one expect they'll be able to safely continue long-acting octreotide until a more effective treatment has been found? So basically, can you use it as long as you want? Are there going to be any side effects or any problems for long-term usage of long-acting octreotide?
Yeah, very good question. I'm not sure that the definitive answer is available to that, but it's something that's really important to consider. It sort of makes you have to step back, though, and look at the whole algorithm for management. So octreotide is an expensive drug, but I personally don't feel that in comparison to all the other interventions, it is that expensive. And so to hold off on octreotide for expense alone, I don't think is a legitimate approach. I know it's limited, and there's parts of the world, I'm sure there are people watching today who are in environments that they actually cannot get it because they can't get it from an insurance perspective. I would say don't be too anxious about going on, going off as being a sensitization. I don't think that has been documented in any way. Interestingly, there's some conditions, especially if you use octreotide for variceal bleeding, when the body learns to work its way around it, that's called tachyphylaxis, or loss of efficacy with time. And we do see that in bleeding, but we tend not to see that in patients who are taking octreotide or lanreotide for neuroendocrine tumor control and or for syndromic control. So in that sense, tachyphylaxis has not really been shown to be an issue. But there are potential issues. Octreotide is an inhibitor of everything. So it affects your motility, it affects your enzyme production, it affects your sugar control. It potentially in long terms can start affecting thyroid function. There's always been a wonder about long-term doses and effects on bradycardia, which is a slower heart rate. And so these concerns, I think, are legitimate, but I think the benefit in most situations outweighs the risk. So for syndromic control, there's no doubt in my mind, octreotide's the way to go. Lowest effective maintenance dose would be the way to go, but since you're using it for tumor control as well, I like going full dose.
Which would be what for sandostatin?
Which
generally?
For octreotide would be 30 and for lanreotide 120.
Okay.
And there are going to be new formulations coming out in various ways that can potentially achieve the same response. Now, in terms of tumor control, if you have non-functional tumors, that becomes a little bit more dicey. I mean, there's now a quick split of a concern about whether long-term maintenance octreotide is good, bad, or indifferent in terms of efficacy. And when I say octreotide, I mean lanreotide as well, in terms of efficacy of PRRT and other interventional therapies. And there is a potential impact on how drugs get internalized into tumor cells, which may be impacted. Hasn't been well enough studied yet for me to go one way or the other. But there are those who say if you have a non-functional tumor and you've just had PRRT, for example, you've had a good effect, should you stop your SSA at that stage and have a holiday, so to speak? And I don't think there's a definitive answer one way or another. I think it's something to discuss with your physician. I can tell you we learned a lot about this during COVID, when patients couldn't come in and get their shots and they were saying, oh my God, I'm going to miss my shot. What's going to happen? My tumor is going to explode. In reality, we tended not to see that much. But taking a holiday, if you're going off to a part of the world where it's hard to get your drug, I think it's reasonable to miss a dose here or there. Do I personally have an answer to that question? I hope I haven't been too confusing. My sense is to continue if you can, but I don't think it's the end of the world if you stop intermittently. And I don't think that I think the benefit outweighs the risk of saying you've been on it for X years, it's time to stop.
Yeah, I think it's a very, very comprehensive answer again. Thank you very much. And to your point with PRT, for example, and like continuing long-acting octreotide, we ask ourselves the same question in the surgical ward. So I know as a matter of fact that after I debulk patients, I look at their pathology, and if they have a favorable pathology or low-grade tumor and sort of what I would consider a low-grade biology, I will actually take them off long-acting octreotide for a while. I know Jim Howe, for example, at the University of Iowa does not do that, but I do think that that's maybe a way to study what the progression-free survival is in his patient and in my patients. But I think that that's really something that a lot of patients are very nervous about, exactly like you mentioned. And I think that's reassuring them that it is okay in certain situations, and that we definitely need more data to study this. I think is really important. All right, let's move on to the next question. So the next question is it possible for non-functional neuroendocrine tumor to suddenly become functional?
I'm happy to take that. That's a very, very good question. And it's actually more complicated than just that simple situation. There are secondary hormonal syndromes that people need to be aware of. In the old days, people with widely metastatic neuroendocrine tumors didn't do well for long enough to actually evolve in time. And whether treatment makes this happen or not is also not known as well. But there are many, many cases described of patients, especially with Zollinger-Ellison syndrome, who develop secondary hormonal syndromes and suddenly develop Cushing's out of the blue. And that's the dangerous one, because Cushing's can be life-threatening very rapidly. So I would just stress that if things change and you suddenly become bloated, or you suddenly get worsening diabetes, or you put on weight, or you develop striae, those are streaks on the belly in the skin that look like Cushing's syndrome, that is something that is often essentially an emergency. Unless you deal with it quickly, you can get into big trouble very quickly. It is not common for a tumor syndrome to become apparent without a secondary syndrome, but the other one that occurs is PTHRP-like tumors that start making a hormone that can give you calcium abnormalities, and that's another one that sort of can creep up unaware. Obviously, in the carcinoid syndrome, the most common of all syndromes, it might be productive, but it's not causing symptoms until there's enough of a mass in the liver that all of a sudden you develop syndromic effects. So there are patients that may have had surgery and thought that their syndrome was gone away, and all of a sudden they had no functional syndrome up front because they, let's say, had a terminal ileal obstructive disease, and now they develop liver mets later on, and suddenly they're getting syndromic. That's not a secondary syndrome. That's actually still the primary syndrome, but it only came up at a later time. Most important, syndrome requires symptoms and blood levels of a product. So if the surgeon or the pathologist or any of your doctors tell you that they took your tumor and they stained it, and it stained positive for VRP or glucagon or PTHRP or any other stuff, don't think that that means you're going to be syndromic, because often there are multiple hormones that can be diagnosed immunohistochemically, but you need to have syndrome in terms of symptoms plus confirmatory blood tests.
So, Dr. Metz, I'm going to add something here. One of my favorite sayings is, we treat the patients, not the tests. So, in fact, being a patient who actually was non-functioning and went to fully functioning 2 years after diagnosis, and who tested negative for a functioning tumor for 2 years, I can personally say that you can go from non-functioning to fully functioning in a period of time. Not necessarily carcinoid syndrome, but there's other functional tumors as well. And to know that that can also change over time and over treatment. So certainly I've flipped more than a few times, and I'm glad to be on the other flip side, so to speak, of non-functioning. But, you know, we treat patients, not tests, and not stains.
An absolute mantra, Josh, got to agree with you. You treat the patient, not the disease. You treat the patient and the symptoms, not the underlying pathology.
Thank you so much. So next question is for Dr. Lon Heath and Dr. Soares. So I'll start with you, Courtney. So how often should a PET scan be repeated if a patient has stage 4 disease? So when do you think it's important to do a PET scan in terms of what potential, perhaps, therapeutic options are out there? And then to Dr. Soares, the question will be, do you routinely use PET scans to see what's going on with your metastatic patients?
It's a great question. And I think sort of like the other imaging question that was asked earlier about CT, where one of the early themes with the answer was, depends, which I know is not that helpful. But I think my answer as far as the frequency of PET scans upon diagnosis of stage 4 metastatic disease kind of depends on the pace of the disease and how fast these metastases have cropped up, how fast the tumors are growing. In the setting of metastatic disease that is being treated and the progression isn't too fast, we'll see it every 6 months to a year doing these PET scans. And again, they're usually somatostatin receptor PET scans in the well-differentiated setting. So,
does every patient need a PET scan before PRT treatment?
And certainly it would to help decide, yes. So certainly to help decide whether or not they're a candidate for PRT, which obviously is one of many tools in the tool belt. So, they may not need one right away, but if PRT is something that's going to be considered, absolutely have to get a somatostatin receptor PET scan in order to determine whether you're eligible. Yeah.
Thank you. Dr. Soares, do you tell your patients you get a PET scan once a year? That's just how I do it, or does it depend?
No, it always depends with MAC patients. It always depends. It's never going to be the same answer for everyone. So yes, I will do a functional study, a dot-a-date PET CT, if I feel that the information provided is going to change my management. either because I'm going to refer the patient for surgery and the surgeon needs to have the right, a better understanding of the volume of disease, or if the patient is going to be referred for PRT, or I wanted to start a new treatment, and it's one of the options above, but I still think that having a better understanding of the volume of disease at the time is important. That's for when the cross-sectional imaging suggests that maybe something needs to be further evaluated, and that's when I will do that. In the setting that someone is very stable in the same treatment or in somatostatin for a very long time, or full surveillance after PRT and is not on any treatment, if the team decided that the patient doesn't need to be on somatostatin post PRT, I tend not to do it, at least for a good 2 to 3 years. And then when the patients get to the 2 to 3 years mark, I might, in discussions with the patients, many times consider doing one just to have a new baseline, with the disclosure that I use to the patient that we might find little disease that we might have not seen on the MRI or the CT scans that we might not even necessarily act on, right? If we see a new tiny little bone lesion that is not causing any problem, I'm not sure that I'm really going to change my patient's treatment based on just the last information. That's why the conversation about 2 to 3 years it needs to be placed before you even go that route, because the patient needs to be prepared, and not every single little thing that we'll find will change treatments. Another thing that I love to see his comments is I do not scan patients post-PRT with DOTA scans. After they scan, I just do my cross-sectional imaging 3 months and 6 months, and then probably much longer than that, but initially the 3 and 6 months. But I do not scan them right away with a DOTA PET CT, and I would love to see your thoughts on anyone else's thoughts on that.
No, I just wanted to make a comment, just because this can happen as well, that the only indication where a 68 gallium or 64 copper DOTA scan is indicated is for bone dominant disease. In patients that because bone dominant disease is not well seen on CT scans, on MRI, so that will be an indication to do 68 gallium 64 copper DOTA scans. That said, I just want to, maybe Dr. Lone Heath, maybe you want to comment further. I know that sometimes insurance may have an issue authorizing those scans, but that said, just to let you know, we work on the ASCO guidelines for the management of well-differentiated neuroendocrine tumors, where we emphasize the need of do a DOTA scan for those patients only with bone dominant disease as a follow-up.
So I would definitely agree that it happens pretty frequently that bone mets are not always well seen on other imaging modalities. And in fact, every once in a while, there are other findings like peritoneal disease or small lymph nodes or something that can sometimes be very difficult to evaluate on conventional imaging, in other words, CT and or MRI. So, bone dominant disease is one example, but again, it's like a patient by patient basis. The other thing, I think personally that somatostatin receptor PET routinely, yearly is warranted. I will say the longer that a person goes without getting one, the harder it is when they finally do get another one to compare back. And so having at least yearly, or I guess if the disease is definitely stable, every 2 years, but as a radiologist, I'll say we can do our jobs a lot better if it's more like yearly. And again, also there are definitely things that we can see on somatostatin receptor PET that may not necessarily be visible on other imaging modalities. As Dr. De Oliveira mentioned, bone dominant disease is one example. If we see a new lesion or a growing lesion pop up and it does not have somatostatin receptor PET uptake, while the other lesions do, then that could be a very early indicator of something we call grade progression. Could be a very early indicator that the disease is becoming more aggressive. And so it would prompt us much more quickly to potentially biopsy that lesion and find out what's going on.
Or even, I'm sure that all of us have seen this, patients that have 2 different types of diseases. So that's another thing that obviously you have to consider. So I'm sure we've all seen it at some point. But I think this one is for Dr. De Oliveira. I think it's an important question And the question is, are pancreatic neuroendocrine tumors thought to be hereditary? Is genetic testing indicated to determine the likelihood that my children will develop this disease?
Yeah, thank you so much for that question, and very important question. And of course, I would like to know the thoughts of Dr. Metz as well. But yes, approximately 10% of pancreas neuroendocrine tumors can be associated with what we call a cancer predisposition syndrome. Most commonly are multiple endocrine neoplasia type 1. We also have von Hippel-Lindau. We also have neurofibromatosis, tuberous sclerosis. Those are the ones that has been associated with pancreas neuroendocrine tumors. Usually the clinical presentations and those cancer predisposition syndromes, besides the neuroendocrine tumors, there are other clinical presentations that are seen. So neuroendocrine tumors is not the only one. Like, for example, for MEN1, they have the tumors of the pituitary gland, they have tumors of the parathyroid gland. The parathyroid gland is the ones that normalize the calcium level in the body, and then they have pancreas neuroendocrine tumors. That said, what we're learning about MEN1 related neuroendocrine tumors is they can also have other neuroendocrine tumors like the thymic neuroendocrine tumors, the bronchial neuroendocrine tumors, ovarian neuroendocrine tumors. There is other neuroendocrine tumors associated with MEN1 that we're learning as well as being associated, not as commonly see as the pancreas neuroendocrine tumors. Then we have the von Hippel-Lindau as well. Von Hippel-Lindau has been associated, besides the pancreas neuroendocrine tumors, with kidney cancer, pheochromocytomas, and paragangliomas. And talking about, I think mentioned earlier about the DOTA scans and two different type of disease that expresses the same receptor, that's something that sometimes we need to understand how do we manage these different situations as well. And also there are other clinical manifestations. So I think it's important to recognize in those familial syndromes, pancreas neuroendocrine tumors may not be the only one clinical implication associated with the syndromes, and there are other things that we follow as well that we try to diagnose at the time of if we suspect that somebody has a familial syndrome. At the same time, the follow-up is different compared to patients that have sporadic neuroendocrine tumors. One thing that is emerging that we also trying to understand is the familial carcinoid as well. And those especially with the small bowel neuroendocrine tumors, there is a familial carcinoma. We're still trying to understand about the genomics of this familial carcinoma, but it can exist in family. Usually those small bowel neuroendocrine tumors are multiple as well, seen in the familial carcinoid, and then it usually affects first generation as well. But that's something that we wanted to understand more about the familial carcinoid. And here at the NIH, we see a lot of these conditions. So that's the reason why, I wanted to know Dr. Metz's thoughts, because he's based on his expertise and experience in the familial syndromes as well.
Yeah, Dr. Metz, so the question is, when do you become suspicion? Does everybody need genetic testing? What's going on there?
Yeah, so let me just quickly start with the conditions that Dr. Del Rivera actually didn't mention. That is actually her area of expertise. So I know it's just because you want to lean more to the GEP-NET side, but pheochromocytoma has exploded in terms of its genetics diagnosis now. And anybody with a pheo, I think, needs to get a good, complete genetics evaluation. And they're all the SDH mutations, A, B, C, D, and there's a whole alphabet soup of them that present in very different ways. They're all familial, but some are highly malignant, some are bilateral, some are more in the neck than in the abdomen, and some are pheos more than paragangliomas less, on the other way around. And so from a diagnostic and a therapeutic perspective, I think that's something that should be important for anybody with a pheo. Now, as far as the pancreatic neuroendocrine tumor syndromes are concerned, MEN1, as pointed out, is the major player, and I agree entirely. I think we didn't mention that earlier, but that's a real indication, in my opinion, for a dotatate scan, because those patients can get pituitary, parathyroid, pancreas as the majors, but thymic carcinomas and thymic carcinoids can be deadly, and if missed, or can be very bad. Those patients also tend to get neuroendocrine tumors in the lung, especially Cushing's-related ACTH-producing tumors, that if you don't find them, you can cause a lot of symptoms. So MEN1 really should be looked for, and it depends on the presentation. So if you present with ZE1, about up to a third can have MEN1. I think it's mandatory to look for, at least get a calcium, but I would go beyond that. I think if you ever have an insulinoma, Anybody with an insulinoma, I think, also has up to about a 50% chance of having MEN1. Those patients would also be screened. And Dr. Del Vera correctly pointed out the other associations with von Hippel-Lindau, neurofibromatosis, Sturge-Weber, etc., rare diseases, but they are associated. I would also mention that there is a group of small bowel carcinoid tumors that may well be of a hereditary nature, and there's a big study going on at the NIH in a different department run by Steve Wank, who's looked at hereditary forms of terminal ileal tumors. And there's a bit of an argument as to whether multiple tumors predicts a familial association or not, but there are genetic associations with CDKN1, and others have noticed potentially a clustering of chromosomal 18 abnormalities in some families with small bowel carcinoids. Now, that doesn't mean everybody who's got a carcinoid syndrome or a small bowel carcinoid should run off and get genetic testing, because I think that would definitively be overdoing it. But I think we're learning more and more about these diseases. And from an epidemiological perspective, there are a lot of new information coming out about this. Why, for example, is carcinoid syndrome so much more common in the United States and Western Europe, whereas in Asia, much less commonly seen, far more commonly seen are rectal carcinoids, which we do see because we're doing lots of colonoscopies, but not as much in the frequency there. So there's all sorts of ethnic and hereditary and genetic influences that I think we will learn a lot more about in time.
I may add just a very quick thing, and again, I would love to know the thoughts of everyone, because we are seeing now more younger patients with evidence of neuroendocrine tumors in the 30s and 40s. Again, there is no guidelines in those situations for younger patients with neuroendocrine tumors when to do genetic testing, but usually my own approach, and again, there we need to have that evidence to confirm that as any patient younger than 40 years old, I like to refer them for a genetic counselor, just to kind of like have a panel for neuroendocrine tumors. That said, the question about who needs to have genetic testing is usually those patients that have other clinical manifestations associated with the syndromes that we all discuss, and younger patients as well. But I would say, like, if you have a patient in 60s, 70s, 80s, I don't necessarily need to have no other clinical evidence of other associated with the syndromes that we discuss. I don't necessarily send the patients for a genetic counselor. But again, that's my own approach. I would like to know the thoughts of everyone. And as Dr. Metz said, any patient with fear of para, all of them needs to have genetic counselor. I agree.
Great, thank you very much. Yeah, I think the bottom line is here, we're learning a lot more. Most patients don't have a hereditary predisposition as of 2023, as far as we know. If you do have a pancreatic neuroendocrine tumor and you have associated tumors, definitely, you got to make sure your clinician looks for these rare diseases like MEN1, von Hippel-Lindau, tuberous sclerosis, neurofibromatosis, and all these other ones. But a majority of non-functioning pancreatic neuroendocrine tumors are not hereditary as far as we know, especially if they are diagnosed in your 50s and 60s with normal, calcium levels, etc. So I think that wraps it up. This was a fantastic discussion. Thank you so much for joining, Heloisa, Javira, David, and Courtney. We will hopefully see you very soon, and I will hand it over to Elise, who is going to give some closing remark for this great day that we had today. Thanks again, and I hope to see you soon.